Okay, let's get started. Good afternoon. It's my pleasure to welcome you to In the Weeds, a panel on medical marijuana, CBD, and Delta 8. I'm Larry Marnett, the Dean of the Vanderbilt School of Medicine Basic Sciences. Today's event is hosted by the Basic Sciences as part of a monthly series called Lab to Table Conversations. Today, we're excited to have with us three panelists who are experts in the science and law of medical marijuana, CBD, and Delta 8. We will be discussing what current science says about their effectiveness and their impacts on the body, as well as the legal trends surrounding these substances in the United States. If you have questions, please place them in the question and answer box at the bottom of your screen. We've already received numerous questions from registrants. We'll be answering as many as we can at the end of the moderated discussion, but we may not be able to get to everyone. So we may go a few minutes over if attendees want to stay for a few more answers. So now I'm going to call on the panelists to introduce themselves. First, Ziva Cooper. Ziva?
Hi, Dr. Marnett. It's great to be here. My name is Ziva Cooper, and I am the director of the University of California, Los Angeles Cannabis Research Initiative, a multidisciplinary research effort to understand the impact of cannabis and cannabinoids on brain, body, and community. And my own research focuses on studying the effects of cannabis and the chemicals in the cannabis plant in people to understand their effects on a variety of outcomes, including therapeutic effects and adverse effects, and comparing those chemicals to placebo. Thank you so much.
Okay, thanks, Ziva. And next is Rob Mikos. Rob?
Well, thank you, Dean, for inviting me to this. Happy to be here. I am the LaRoche Family Chair in Law here at Vanderbilt University. I'm at the law school. For the last several years, I've actually taught a course here on marijuana law and policy. And I've also researched and written extensively on a lot of different topics related to marijuana law and policy, oftentimes focusing on trying to clarify the roles that different government actors, federal, state, and local, play in shaping our policy towards marijuana. So happy to be here today.
Okay, and finally, Sandeep Patel. Sandeep?
Hey, good morning. Thank you, Larry. I'm a professor in the Department of Psychiatry and Behavioral Sciences here at Vanderbilt University Medical Center. I have a background in cannabinoid pharmacology, biochemistry, and I'm very interested personally from a research perspective in understanding how cannabinoids, as well as endogenously produced cannabinoids within the brain cells, regulate brain function, and how understanding this system could potentially be used to advance therapeutics development for a variety of psychiatric disorders.
Okay, thank you. Well, we've got a great panel, so let's get started. We're going to begin with a discussion of marijuana and then transition to CBD and Delta 8. So to begin, Rob, could you give us a brief overview of state medical marijuana laws?
Sure. So at this moment, we have 37 states, as well as the District of Columbia, that have legalized the use of marijuana as a treatment for laundry lists of different medical conditions and symptoms associated with those conditions. Those lists vary a little bit from state to state, but they commonly include things like chronic pain. They include wasting syndrome associated with AIDS and HIV, nausea associated with chemotherapy, and more recently, a lot of states have added post-traumatic stress disorder to their list of qualifying conditions. So in these states, if you're an individual who's been diagnosed with one of those conditions, and if your physician has told you that your condition might benefit from the use of marijuana, then you are allowed, as a matter of state law, to use the drug, to buy it from a state licensed dispensary, possibly even to cultivate it yourself. Now, it's important to note that the federal government continues to ban marijuana outright. But for the last several years, especially with respect to medical marijuana, it stopped enforcing that ban. So as a practical matter, really those states that have legalized marijuana for medical purposes, their law is practically speaking the law of the land in those states.
Okay, and what's the definition? What's the legal definition of medical marijuana in those states?
It's a great question. So it's a grab bag. So generally speaking, marijuana refers to the cannabis plant and anything extracted from the cannabis plant that contains more than trace amounts of the psychoactive chemical Delta-9 THC. And we'll be talking more about that in a moment. But the products that you see in dispensaries in these states, the medical marijuana that you see, there's a lot of variety among those different products. And that's because there's a lot of variation in the cannabis plant. You might have one cannabis plant that has a very high concentration of that Delta-9 THC and very little else in it, few other cannabinoids. You might have another plant that has a lot of CBD in it, but very little Delta-9 THC. So that's one way that medical marijuana really differs from prescription drugs that your doctor might prescribe, that you might buy at a CVS pharmacy or a Walgreens. Something like Percocet is a very known quantity. It is defined very precisely. You know exactly what you're getting when you go into a pharmacy to get that. Again, medical marijuana, much more of a grab bag, and it's really up to patients to kind of decide for themselves which of those strains, which of those formulations of medical marijuana is going to work best for them.
Okay, Sachin, just kind of following up on Rob's comments there. So how do the components of medical marijuana differ, say, from each other? He kind of touched on that, but from CBD.
Sure. So, marijuana, the plant, produces many different substances, chemical entities, sometimes referred to as cannabinoids. So the most commonly known cannabinoids are, of course, as Rob mentioned, Delta-9 THC, which is the primary psychoactive component of the plants. CBD, or cannabidiol, is another major constituent of cannabis plants by weight. And there are a number of others, up to 100 or maybe more minor cannabinoids that are produced by these plants through sort of sequential actions of the enzymes that ultimately end up producing THC and CBD. So there's lots of chemicals that are produced, most of which we don't really understand their effects in terms of the biology. We understand the most about Delta-9 THC since it was discovered to be really the primary component of the plant that causes the subjective effects in humans and sort of the intoxication and all the other things that go along with cannabis consumption. So CBD and THC are different molecules. They act at different targets in the brain. They're structurally very similar, but have distinct properties in sort of biological systems like the human brain and body.
Okay, and are there differences between the marijuana that people consume today and what they were, say, consuming in the 70s when there was a lot of attention drawn to this?
Right. So as Rob mentioned, the plants have been cultivated, through by humans to essentially select for different strains that people might find uses for. So on the one hand, you have hemp, which has essentially no THC or very, very low amounts of THC, but very high levels of CBD or cannabidiol. On the other extreme, you have plants that have very high levels of THC these days, as opposed to maybe 20 or 30 years ago, THC concentrations in plants were anywhere from 1% to 3%. Now you can have THC concentrations as high as 25% or more. And that's been through cultivation to select for the enzymes that preferentially will produce Delta-9 THC from these precursors and produce less CBD. And in general, there's a bit of a yin-yang where plants that produce a lot of THC will produce less CBD, whereas plants that produce a lot of CBD generally have low amounts of THC.
Okay, thanks. And you said that that they act in the brain. So why do they act in the brain? These are, components of plants. So maybe you and Ziva could take a shot at that.
Sure, I can start and then I'll hand it off to Ziva. But I like to think of this as a good analogy is thinking about opioids. So clearly there are opiates that are derived from plants. Opium poppies produce molecules that act on the human brain to produce a variety of effects. The brain also produces endogenous opioid peptides like endorphins that are released during pleasurable activities and things like that. Both of those compounds act at the brain on opioid receptors, and the same is true for cannabinoids. So the THC produced by cannabis plants acts at a cannabinoid type 1 and 2 receptor within the brain and peripheral organs of humans and most other mammals. There are also these endogenously produced cannabinoids that also act at that same type 1 and type 2 cannabinoid receptor in the brain. So the body and the brain have these receptors as part of a normal physiological function. It just happens that this molecule produced by cannabis plants also interacts with this receptor quite well. And when people ingest it or take it in some way, it exerts a lot of effects through the brain and body by interacting with this particular receptor, a cannabinoid type 1 and 2 receptor.
Okay. Ziva, you wanted to comment on that?
Yeah, that was a great introduction. And I also want to add that what we're seeing in places where medical and non-medical use have been legalized or regulated is a interest beyond just the Delta-9 THC and CBD. We're also seeing a lot of interest in some of these other minor cannabinoids that Dr. Patel hit on. For example, cannabigerol, CBG, CBN, Delta-8 THC, which we'll talk about. And then there are also chemicals in the cannabis plant that are shared with other plants, and these are called terpenes. Terpenes provide the smell and the taste of cannabis, as well as other herbs and fruits and vegetables. And some people think that these terpenes also produce biological effects that might be therapeutic. And what's interesting is that a lot of people think that even though these chemicals are, they're produced by the cannabis plant, that they would naturally interact with our endocannabinoid system, with these receptors that Sachin is describing. But the truth is that a lot of these chemicals have many actions across the brain and the periphery that aren't necessarily related to the cannabis or endocannabinoid system. And so we're just now starting to learn about even CBD's effects. People think that CBD acts directly on this cannabinoid system in the body, but we're learning that it actually works at a lot of different sites in the brain and the body. And what's interesting is that even though, let's say in Los Angeles, where you can walk into a dispensary and you can get all these different products with different chemical profiles, and people think that it interacts with the cannabinoid system, we're just now starting to learn that they can target other systems and have other variety of effects.
So just because CBD is a cannabinoid doesn't mean it's going to act just like THC. It may not even bind to the same receptors.
Exactly. And one of the key differentiating things between CBD and THC, or one of the primary areas that's really relevant to public health, is that we know that Delta-9 THC and CBD are both psychoactive. They both act in the brain and they both produce certain behavioral effects. But Delta-9 THC is responsible for the intoxicating effects of cannabis. It is known to be responsible for the effects that people experience with respect to memory impairment or attention deficits when they're using cannabis. CBD does not have those same effects. When people take CBD, you don't feel the intoxication, you don't feel high, you don't necessarily feel a memory impairment. And so there's a really important distinction between these two molecules that I think in part has led to this burgeoning interest in CBD itself, because there are signals that it might be therapeutic without those adverse effects that are associated with Delta-9 THC.
Okay, and so just you kind of talked about some of the effects, and it's really fascinating. We're going to get to CBD a bit more in just a second, but with regard to medical marijuana, what sort of adverse effects or side effects would it have? And We got a number of questions about whether it interacts with alcohol or could be used to treat alcohol addiction. Anybody want to take that one?
Ziva, you want to start?
Yeah, so I'm happy to address this. And one thing that's important to remember about these adverse effects of Delta-9 THC is that the adverse effects, as well as the potential therapeutic effects, are really dependent on the dose that people are exposed to. It's really dependent on how people are using it. For example, some people are smoking cannabis with Delta-9 THC versus taking pills or using edibles. And so that also can impact the outcomes with respect to the adverse effects and therapeutic effects. And also you have to remember the actual individual, the person, their age, their sex, if they're male and female, how much prior exposure they've had to Delta-9 THC. These are all factors that go into what we might hypothesize would be the effects if that individual takes Delta-9 THC. So some of the primary adverse effects that we think about that are associated with Delta-9 THC is this type of intoxication. Again, and this is a high, a altered state of reality that is related to how much Delta-9 THC exposure there is and how much experience that person has and how they're using it, smoked versus oral. We also know that there can be cognitive impairment, memory impairment that we just alluded to. There's the risk that people can develop what we call dependence or develop cannabis use disorder if they use cannabis with THC repeatedly and frequently over time, where they'll develop a negative relationship to taking that substance or maybe withdrawal symptoms when they stop using it. And these are some of the effects that people should be aware of, as well as some of the other effects that we think are associated with use of Delta-9 THC, such as development of schizophrenia and psychosis, which we might touch on later on. Now, I just want to point out that even though there are a host of adverse effects, we also know that Delta-9 THC is responsible for some of the therapeutic effects of the cannabis plant. So for instance, in the 1980s, the FDA, the Food and Drug Administration, actually approved THC for medical conditions, including appetite needs. So in some patient populations that had suppressed appetite, it was approved to help increase appetite. It was approved to help reduce nausea and vomiting in certain patient populations. So while THC has adverse effects, we also know that it has some therapeutic effects, as well as therapeutic effects that aren't approved by the FDA, but we know in the literature there are certain signals for, such as maybe being helpful for chronic pain, maybe being helpful for sleep and anxiety.
Okay, great. And with regard to alcohol, Sachin, did you want to comment on that, or can it be used to treat alcohol addiction?
Yeah, so this is an area of real interest. There's actually a large book coming out by the National Institute on Alcoholism and Alcohol and IAAA about this thing, about this concept of THC or cannabis alcohol interactions. There's two schools of thought. There's thoughts by some experts in the field that cannabis use can actually reduce alcohol consumption. There's also thoughts that the co-use sort of acts synergistically. So people use the two together to sort of enhance intoxication or positive states that are induced by the substances themselves. And there's probably evidence for both of those in the literature, depending, as Ziva mentioned, on many factors, including the individual, the motivations why people are using alcohol and cannabis, and their history with these drugs. So it's not clear. I have not seen any clear evidence that cannabis can be used to treat alcohol withdrawal. Alcohol withdrawal is a potentially life-threatening condition and can be associated with seizures, autonomic instability, and many other medically very serious things. And I don't think I would support the use of cannabis to treat alcohol withdrawal at this point. As a physician, there's no evidence for that. But it's complicated, and there is certainly a lot of co-use between alcohol and cannabis. The motivations behind that are not entirely clear.
Yeah. Okay. All right. Well, thanks. This is great. A terrific introduction into medical marijuana. So why don't we shift a little bit to CBD and Delta 8? So Rob, what's the difference legally between hemp and marijuana, and how does this play into the legality of CBD and Delta 8?
So as I mentioned before, marijuana is cannabis that has more than trace amounts of Delta-9 THC. Hemp is everything else. So hemp is defined as the cannabis plant when it has less than, I think, 0.3% by dry weight Delta-9 THC. Historically, the law made no distinction between the two. All cannabis was marijuana. There was no such thing as hemp. But in 2018, Congress did something interesting in a farm bill. In that measure, which was sponsored by Senate Leader Mitch McConnell, Congress legalized for the first time hemp. It made this legal distinction between cannabis plants with very little Delta-9 THC and cannabis plants with lots of Delta-9 THC. And that's the reason why over the last few years, and lots of states followed the federal government's lead on that, but that's the reason why in the last few years, you've seen this explosion in the availability of CBD and also these Delta-8 THC products. Here in Nashville, you can drive down the street and you'll see coffee shops offering dabs and CBD in your coffee and Delta-8 THC. So even in a more conservative state, we see this stuff being offered. And the reason is that as long as the cannabis plant doesn't have much Delta-9 THC in it, you can go ahead and extract whatever you want from it and sell it under federal law and under most state laws. So you could have a hemp plant, doesn't have much Delta-9 THC in it, but it might have a lot of CBD in it. So you can extract that CBD legally and then turn around and sell it on the market. I think that the Delta-8, similar story there. You can extract it from the hemp plant because the definition of hemp is sort of myopically focused on Delta-9 THC. The only quirk with that on Delta-8 is kind of in a gray zone because the FDA has come back and tried to schedule Delta-8 THC as a Schedule I controlled substance, as a banned substance, depending on the way that you get it out of the cannabis plant. If you're just extracting it, it's fine. If you're synthesizing it, if you're making it from some other cannabinoid like CBD, then it's still banned under federal law.
So yeah, so that's an interesting point that you can extract CBD in really large amounts, and you can also convert it to Delta-8 chemically. It's a pretty simple reaction, but it's also not so easy to purify. So a lot of the Delta-8, from what I understand, is really a mix of a lot of different things. But so then let's talk about the biology of Delta-8 just a little bit, because Ziva told us just a bit ago that CBD binds to different receptors than THC does. What about Delta-8? It's really a close structure to Delta-9. Does it bind to the cannabinoid receptors that Delta-9 binds to?
Yeah, I can start, and then I'll turn it over to Ziva because I know she's got some information on this too. I can speak more to some of the sort of the pharmacology and biological experiments that were conducted many years ago now in laboratory settings, where people were really looking at these different molecules, including Delta-8, Delta-9, and many of the minor components that Ziva mentioned earlier. So what we do know is that Delta-8, it's structurally very, very similar to Delta-9 THC. There's just one, I mean, you're the chemist there, you can talk a little bit about this, but the double bond is just moved over on one of the rings a little bit. So it's very, very similar. And as you might suspect, given the marketing, it actually does bind to the cannabinoid type 1 receptor the same way THC does in theory. Although it's not nearly as potent as Delta-9 THC. So the amount you need to take to exert the same effect is actually anywhere from 3 to 10 times. So you would need to take up to 10 times more Delta 8 THC to potentially get the same effect you would get from the Delta 9. There's also some evidence that it may not exert quite as much action at the receptor. So not only do you need to take more, but even if you take more, it may not have exactly the same type of punch that the Delta 9 does. But it does interact with the cannabinoid type 1 and 2 receptor, which makes it distinctly different from cannabidiol, the CBD. But as you mentioned, it can be synthesized quite easily with a little bit of some organic solvents and some acid and some heat and a few other things that you could convert these large amounts of CBD that come from hemp plants into Delta 8. But as you mentioned, there may be a lot of other molecules that come along for the ride when people are synthesizing or trying to make this transformation with that.
Yeah, thanks. That's great. Ziva?
Yeah, and just to add to what Dr. Patel said is that there actually have, unlike a lot of these other chemicals in the cannabis plant that people are using that haven't yet been tested in humans, there actually have been a couple of studies back in the 70s and 80s, and even one clinical study in 1995 on Delta 8 THC. And exactly what Sachin is saying is that, you know, what these researchers have found is that compared to Delta 9 THC, the participants do experience some intoxication and some cardiovascular response that is similar between Delta 8 and Delta 9, except with Delta 8, you just don't get that same magnitude of response. So the intoxication, the increases in heart rate, you know, you can give whopping doses, but you still don't reach that same level with Delta 9 THC. And in the 1990s, I think because researchers were encouraged by the fact that this Delta 8 might act therapeutically like Delta 9, but not produce the same intoxication, there was a study in children with cancer to look at how Delta 8 might be helpful for nausea and vomiting in that patient population. And there was actually a positive signal with minimal adverse effects. Now, when I see Delta 8 THC advertised, you know, we're all getting advertisements for it. If you're a cannabinoid researcher, you get all of these pop-up ads. And, you know, it's being advertised as the light Delta 9 THC. So in some respects, that might actually be true. But at this point in time, there's been so little data in the human laboratory space. We don't know what happens when you smoke it. We don't know what happens with respect to other constituents that might be in there. Sachin also alluded to the fact that, you know, it could be a messy synthesis. The products that people are buying when they think that it's Delta 8 could actually have Delta 9 in it. And that has some implications for the person who is using it, right? So if they're actually getting Delta 9, then you would expect to have that intoxication, increases in heart rate, the decreases in memory and attention. And consumers just aren't aware of how much Delta 9 is in the product. The products are not regulated across states. And this is something that people should be mindful of.
Okay, terrific. So then from therapeutic efficacy, could we talk a little bit about mainly CBD, because that's the one that is so widely available and easily produced. So what's it used for? Sleep, pain. We heard from Rob what medical marijuana is used for. How does that compare to CBD?
I'll start with one thing, and then I'm going to turn it over to Ziva because she's really the expert in terms of the therapeutics of this. But I can say that as everyone on the call knows, and maybe a lot of people in the audience, that CBD was actually approved by the FDA last September in a formulation or a company formulated drug known as Epidiolex. And this was FDA approved for the treatment of intractable seizures associated with Lennox-Gastaut and Dravet syndrome. These are very severe intractable forms of seizures that often don't respond to conventional medications. And there were some clinical trials that were performed that met the FDA standard for showing clinical efficacy in patients with these types of severe intractable seizures. So there is now an FDA-approved CBD that can be prescribed by neurologists and physicians to treat these types of patients with epilepsy. As far as the other non-FDA approved indications and what their therapeutic implications might be, at that point, I think I'm going to turn it over to Ziva.
Yeah, Ziva, go ahead, and then I have a question, follow-up.
Yeah, and so it's interesting, the movement by the FDA to approve this cannabidiol for these pediatric seizure disorders was really a landmark approval because it was the first time that a cannabinoid had been approved for a therapeutic indication in 20 years. It's the only cannabinoid that's actually made from the plant itself. It's not synthetically derived that it's approved for. And it's also the first time that a cannabinoid is approved for this specific indication. And one thing to note is that the doses that are recommended to help with these seizure disorders are a lot higher than what people are actually using when they're getting it from their dispensaries. For example, people who were in this trial were exposed to 1,200 milligrams a day, 2,400 milligrams of CBD a day. The amount of cannabidiol that people are using when they get it from the dispensaries are a lot lower, usually ranging between 5 milligrams to 100 milligrams on the high end. And what's also interesting is that seizure disorders is not one of the main indications that people are using CBD for. They're usually using it for pain, for anxiety, and for sleep. Those are the primary indications. I apologize if I just blacked out. And based off of clinical trials, there's very little information about CBD's effects on its own for pain. So CBD has been studied in conjunction with THC for pain, and it looks like the combination might be helpful for pain. But CBD by itself, there hasn't really been much of a positive signal, even though so many people are using it for pain. For anxiety, we're just starting to learn based off of clinical trials that CBD might be helpful for anxiety at high doses. And the jury is really out with respect to CBD's helpfulness for sleep. One other indication that's been studied is the potential for CBD and its helpfulness for substance use disorders. So there's been one really nice study looking at CBD compared to placebo for people who have opioid use disorder. And there is a signal that CBD might be helpful for some symptoms that are associated with opioid use disorder, like drug craving and anxiety that goes along with that drug craving. And now there are many clinical studies that are planned or that are ongoing looking at CBD for other types of substance use disorders, for example, tobacco use disorder, alcohol use disorder. So this is a really rapidly evolving area, and there's a lot of opportunity here simply because so many people are using CBD for so many different indications. And if you look at some of the animal literature, and Sachin can speak to this, there does seem to be some positive signals for a variety of disease states in animal models that CBD might be helpful for.
So the clinical studies, will those be done with Epidiolex? And you have a situation where you have a relatively pure compound that the GW Pharmaceuticals has made. No advertisement there, and yet people may not be using it because they think that they've got CBD available at every gas station in town.
I'll speak to this from personal experience that despite the fact that CBD is everywhere, including gas stations and convenience stores, as a scientist, it's actually quite difficult to get. So as a scientist, as a researcher who's giving this to people, you need to make sure that the product is pure and safe and free of pesticides, free of THC, that it's reliable, stable from batch to batch. And it's actually quite a challenge to find a source of CBD. And it's not so easy to ask the company that's making Epidiolex to be able to provide their product for your studies for many different indications because it's expensive and they're very interested, those companies are very interested in studying specific disease states. They might not necessarily be interested in, let's say, studying arthritis or PTSD. So these are some important obstacles and hurdles to actually looking at its effects in the laboratory in clinical studies. I will say that there is a movement from researchers to want to study the types of products that people are using. So Epidiolex, which is a oral formulation, very high doses, that's not what people are using. So people researchers are very interested in knowing, well, how do those 5 milligram doses that people are using from dispensaries, how does that impact health outcomes? And so researchers are trying to work towards establishing if those doses can have a positive health outcome, or what are some of the adverse effects as well that we should know about.
Okay, yeah, that's that's terrific. Thank you very much. I want to shift for just a second to, there's been talk of federal legislation. So I want to go back to Rob. And what is the potential impact of federal legislation, both on state laws as well as the current economics of production and sale? And I'll follow up a little bit more on the economics of this.
Sure. So there are a lot of different proposals before Congress. The latest one, there was a draft put out called the Cannabis Administration and Opportunity Act that was announced this summer. People were allowed to give comments on that particular piece of legislation. What all of these have in common is that they would legalize marijuana at the federal level, both for medical uses, but also for non-medical uses as well. But it's important to note that federal legalization wouldn't necessarily change state law. So I think all of these federal proposals would allow states like Tennessee to continue with their bans, outright bans on marijuana. And that's similar to the way that we sort of extricated ourselves from alcohol prohibition. The 21st Amendment was ratified back in the early 1930s. It wasn't until the mid-1960s that the last state, Mississippi, lifted its statewide prohibition on alcohol. So even though you could have federal legalization, you wouldn't necessarily see a lot more states legalize marijuana medically or otherwise. But federal legalization would have a big impact on the market. Because right now, in those 37 states that have legalized medical marijuana, the 17 or so that have legalized adult use marijuana, we have these very insular, odd bubble markets for marijuana. It's not traded across state borders, at least legally. So you go to Colorado, the stuff you see on the store shelves in Colorado is grown and processed in Colorado, not from some other state. And the big reason for that, I think, is that we have federal prohibition. And lots of states have said, we've got to keep this within our borders. Once that federal prohibition is lifted, I think you'll start to see the emergence of this new national market. And it probably means you're going to get a lot of really big companies that enter into the market and take over a lot of the space. And they're going to have economies of scale. They're going to be able to grow the plant cheaply in California and Oregon rather than in a warehouse in Michigan or Massachusetts. And I think you'd see the price of marijuana drop across the country, the price to consumers, which could raise some public health concerns. You might also be concerned that if you've got this concentrated market, maybe akin to tobacco or alcohol, those companies in that industry might be able to push back against sort of public safety minded regulations of the industry as well. So we will see changes to the economics of the industry, but the moment that Congress legalizes marijuana doesn't mean it's going to be legal in Tennessee or Idaho or
Yeah, great. And who's making money on marijuana right now? I think that there are lots and lots of people growing it. The idea is that, oh my goodness, this is a bottomless pit of cash. Is that really true?
The lawyers certainly are, because there's so many. It's great for us, right? Because there are so many legal questions out there. The picks and shovels, the people who sell inputs are making a lot of money. The people who are in the industry, there are some who are making money off this because each state is kind of granted them, in a lot of states, a state licensed monopoly or oligopoly. So in New York, for example, when they had just medical marijuana, there were only a handful of companies that were licensed to grow, process, and sell the drug. So if you got one of those licenses, you can make money off of that. It's tougher in other states like Colorado, where they have 1,000 companies right now that are licensed to grow, process, or sell marijuana. It's tougher to make a buck on this, and it's going to get a lot tougher the moment Congress legalizes, because you're going to be facing national competition out there.
Are there any estimates of how much money, let's say that at some point all 50 states have legal marijuana. And so it's not criminalized any longer. So is there any estimate on how much money might be saved from the cost of incarceration?
Yeah, so there have been estimates in the past. Marijuana historically accounted for a staggering number of arrests in the criminal justice system. Almost 1 million people every year were arrested for marijuana offenses, maybe 10, 15 years ago. And those arrests cost money when people are actually prosecuted. It doesn't happen too often for simple possession, but it does happen for trafficking offenses. Costs money to prosecute them, costs money to put them in prison. There were estimates pending that number somewhere from $3 to $5 billion annually that we expended just on policing marijuana prohibitions in the United States. And those expenditures, they don't go away entirely, because now you've got this regulatory apparatus. You need to supervise the legal industry, you need to inspect it, test it, and so on. But those numbers would drop dramatically, I think, in the criminal justice system.
All right, great. And, just from listening to a couple of Ziva's answers on therapeutics, it kind of seems to me that public policy, there's not the science in place to support public policy right now. Is that a correct conclusion? And if that's true, then what are the obstacles to providing better scientific basis for regulation, and how do we overcome them? We'll start with Ziva on that one.
That's a $64 million question. You are absolutely correct that public policy is outpacing science at this point in time, both with respect to how these products can be used therapeutically. So Rob mentioned that each state allows cannabis to be used for specific indications. Those indications vary considerably between states. And it's not necessarily, those indications are not based off of evidence, which is very confusing to the patient and to the physicians who are receiving questions from the patients. So we have the medical, market, and then we have the non-medical market, where we're starting to see these emerging products come about that are not just high strength THC cannabis. We're not just talking about cannabis with 30% THC, which is very different than the cannabis that was available in the 1990s, which had 5% THC. But we're starting to see these extracts that are almost 100% THC that people are starting to use. And there's a great deal of concern with respect to the public health safety of these types of products. What happens when people start using this? They stop using the plant. They start using these extracts on a daily basis more frequently, and there are just so many unknowns. Those products have not been tested in the lab. We do not know the extent to the adverse effects that could occur when people are using these in the short term or the long term. So these shifting public policies is definitely calling on an urgency for the science to catch up and to keep up with the fluctuating industry across the different states. And certainly, if there is federal regulation, federal legalization, even more so, I think there's a couple of advantages to federal regulation, federal legalization. One is that there can be uniform regulation. There can be a governing body that says, these are the guidelines that should be followed in the marketplace. That does not exist right now. It's really a patchwork of regulations across states, some of which are more sophisticated than others. So it'll be interesting to see what happens if the federal regulation does pass at some time in the near future.
Yeah, that seems to me to be a great transition point to let's begin taking questions from the audience. And as I said, we've had a lot already from just the registration process, and we're getting a lot more in through the question and answer box. So I've got a few that we'll start with, and we'll just keep going. So you talked about the risk, particularly of high THC, and we kind of touched on this a little bit earlier, but is use of marijuana at a young age connected to negative mental health outcomes in adolescence or as an adult? And there were multiple questions from the audience on the linkage between marijuana use and schizophrenia in adolescence. And then are there any effects on cognition in youth or later in life? So Sachin, you want to start with that one? I'll give you an easy one.
So it's somewhat easy, but it's also, as with most questions about mental health and substance use, it's complicated. In terms of what's not complicated is that there have been many studies over decades that have really looked at the association between cannabis use during adolescence and subsequent development of psychotic disorders, which include diseases like schizophrenia or schizoaffective disorder. And the vast majority of those have shown positive associations, and the increase in risk is anywhere from a little over 1 to sometimes up to 4 times the risk, depending on the study, the subpopulation, and things like that. So there's clearly an association between cannabis use during development and subsequently being diagnosed or experiencing symptoms of psychotic disorders like schizophrenia. There's also some evidence more recently in the past 5 or 6 years showing that the degree to which people use cannabis or the amount that they use during adolescence might actually confer a higher degree of risk. Putting that aside, these are associational studies. These are not randomized studies where people are assigned to use cannabis or not and then tracked over time. So really, causality can really not be conclusively ascribed to that. So the studies so far do not mean smoking cannabis during adolescence causes schizophrenia later. There are many alternative explanations. So there could be, for example, common risk factors, genetic or environmental, that lead people to both use cannabis and develop schizophrenia later. And so later in life, those two would be associated, even though they're not causally related. They're stemming from some common risk factor that we don't really understand. So there's many explanations for why that association exists, but the association is strong and reproducible and shown in many different populations over a long period of time.
Is there kind of maybe a sensitivity window in age where if somebody who might be susceptible smokes it during that period of their life, that they're more susceptible to, say, a psychotic break than if they wait till they're 21 or 25?
Yeah, so the 12 to 18, 12 to 15 window has been described as being this more sensitive period. I think people that use cannabis after that, the risks are dramatically lower. So it is sort of this late teenage, window overall that seems to be more sensitive.
So this just kind of comes back to Ziva's comment that there's just so much that we don't know. And I'm going to guess that money to do research is a big obstacle to us getting the kind of knowledge that we need. So I'm going to go to Rob here for a second. Rob, we've got some folks that want you to make a prediction for what's going to happen in Tennessee with regard to legalization. We got an over and an under on this one. I think we got DraftKings is working on this.
There may very well be a category on DraftKings, or certainly in a British pub, maybe not about Tennessee, but about here in the US. I'm skeptical that Tennessee will do anything in the near future. There have been a number of proposals put before the assembly to legalize medical marijuana. Certainly not adult use. And that's the way most states have proceeded. They dip their toes in the water, legalize medical, and then turn to adult use. But each of those proposals, for various reasons, hasn't gotten the votes to get through. So I'd be surprised if it happened in the near term, although in the long term it could happen. One big difference between Tennessee and a lot of other states like Colorado and Oregon and California, so the pioneers in this movement, is that we don't have a ballot referenda process to speak of, where people could go around the legislature. That's how these things got done, especially in those early adopters, actually probably in the majority of states, it's easier to go around the legislature, get it passed popularly. You may not like what you get in the end, but we don't have that here. So I'd be surprised if we saw anything in Tennessee in the short term, but maybe 5 years down the line, 4 years down the line, certainly a possibility.
Okay, and another one for you. So historically, the war on drugs has adversely impacted minority and impoverished communities. So how is the legal world thinking through addressing these inequities as they transition to legalization of marijuana and recreational marijuana nationally?
Yeah, it's a particularly big issue with recreational marijuana. So historically, Blacks and other minorities were arrested at 4 to 5, maybe even 6 times the rate as similarly situated whites for marijuana offenses. So the brunt of those marijuana arrests I talked about before, those fell disproportionately on communities of color. To try to deal with that going forward, states that are legalizing marijuana, they're really doing 2 things. One is they're looking back and they're saying, what can we do for those people who were in the past caught up in the net of prohibition and the war on drugs? So they might release individuals from prison who are still serving terms for marijuana offenses. They might expunge prior criminal convictions for marijuana offenses, because those, even an offense 20 years ago, a conviction 20 years ago can have lingering consequences for employment and so on. The other measure is more forward-looking. States, one of the big drivers of legalization are the new tax revenues. They're collecting a lot of tax money from marijuana sales, to the tune of billions of dollars when you put all the states together. So a lot of states are trying to take part of that money and reinvest it in these communities that have been disproportionately hit by the war on drugs, and invested in infrastructure there, in schools and community centers and so on. Maybe even give some benefits to individuals in those communities in terms of giving licenses to grow and sell marijuana going forward. So that's the more forward-looking, what do we do in the future?
Okay, great, thanks. So we're kind of hopping around with topics here a little bit, but Sachin, you've talked about this endogenous cannabinoid system or endocannabinoid system. So what's it actually there for? And how come we're not high all the time if we've got this system that we're using?
Sure. So the system there in terms of the receptors that we mentioned earlier that Delta 9 THC binds very well to, that's situated throughout the brain and spinal cord of mammals and obviously including humans, do a number of things, and many of them are quite predictable. So endogenously produced cannabinoid molecules in the brain act on this receptor to regulate things like appetite. Not surprising, given that's one of the effects of consuming these exogenous cannabinoids like Delta 9 THC. Also important for things like mood regulation, memory function. So sort of those are the kind of big types of things that cannabinoids are involved in. Regulation of stress responses, something that our lab studies extensively, and how these cannabinoid molecules regulate resiliency to stress and depression, and things like that, which are very well cited reasons why certain subpopulations of people use cannabis chronically. So many of the things that these endogenously produced cannabinoids act on the type 1 receptor to do are things that are partially mimicked by THC. And so the question as to why are we not high all the time is complicated, but also somewhat simple. So when people use THC, your brain and your body gets a flood of these molecules that activate the receptor sort of indiscriminately throughout the brain. Whereas normally these receptors may be activated only under certain situations, or only in some parts of the brain one at a time, or at very low levels chronically. And so people are not necessarily feeling high all the time because of the sort of spatial temporal regulation of these normal biological processes. But when people take cannabinoids from the plants, it's like you're flooding your whole brain and body with these molecules, and they may be activating receptors that maybe normally are only activated under very certain circumstances, but now you've kind of flooded the system, and that's why you get these intoxicating effects, these robust effects on episodic memory and many other things.
Okay, thanks a lot. And Ziva, do we know how CBD works? Do we know what its molecular targets are or is?
So there are tens of hypothesized ways that CBD might act. And some of these are related. We talked a little bit about how CBD doesn't work at the CB1 receptor like THC does, but there are some hints that it does interact with the endocannabinoid system. There's one hypothesis that it prevents the degradation of certain endocannabinoids, so it might prolong the effects of these endocannabinoids. People think that it acts at other receptors that are involved with mood regulation, as well as inflammatory responses. So this is an area of interest in our laboratory where we're looking at CBD for rheumatoid arthritis, which is, marked by inflammation and inflammatory responses. So there's a great deal of interest in how CBD might impact inflammation, which is a part of a lot of different disease states, both inflammation in the brain, the central nervous system, as well as the peripheral nervous system. And this is an area, how does CBD work to elicit its outcomes, its therapeutic outcomes, is an area of intense interest right now. And it's clear that it really depends on what it is you're looking at. So if you're looking at CBD's effects on anxiety, the way that it acts in the brain and the body is probably different than how it might act to alleviate inflammatory responses for some pathological states. And this makes CBD a very complicated drug, but also one that is exciting.
Okay, thank you. So we are coming near the 1 o'clock hour, but one of the questions that has come in over the Q&A, which I think is a good one. So for each of you, do you have like one or two resources that you would recommend people read to get more information or as a follow-up to what they've heard today? If you have something on the tip of your tongue, you can raise your hand and speak up.
So I will put in a plug for a publication that Sachin and I both worked on, which is outdated now, but it was published in 2017 by the National Academy of Sciences. And it really provides an overview of the literature related to the therapeutic effects of cannabis and cannabinoids, the adverse effects as well as therapeutic effects. And it has a really nice introduction that Sachin had a huge role in writing about the endocannabinoid system.
There we go.
Yeah. And so, people should understand that it was published back in 2017. A lot of things have changed, but we teach a course at UCLA to undergraduate and graduate students, and we use this as, the primary textbook for people to understand, what do we know about the health effects and health outcomes of cannabis use and cannabinoid physiology.
So
I believe this is free, correct? If you go to the National Academy of Sciences website and type in health effects of cannabis, I think all you have to do is register and you have free access to this entire text.
Awesome. Great. That's terrific. Rob, what about the legal aspects?
Yeah, so in terms of the law, I can recommend my own textbook. I wish I had a copy here within arm's reach. I'm sort of attached to my computer. But it's Marijuana Law, Policy, and Authority. Touches on some of the stuff I talked about today, includes some of the earlier scientific reports, but provides a nice introduction and overview of the legal issues. The other thing I'd recommend, John Calkins, Bo Kilmer, and some other folks at RAND, the think tank, have put together a nice book. You can get it on Amazon. It's easy to read. It's called Marijuana Legalization, Everything You Need to Know. That might be hyperbole there, but it's a great introduction, great overview of a lot of the policy issues, including some of the ones we've talked about here. I highly recommend it.
Okay, and I've got one last one, and then I think we'll let everybody go. But with regard to, and I guess this gets to the anxiety issue, but what about elderly patients with Alzheimer's disease as a possible way to control agitation in those individuals. CBD, THC, Delta 8. Any thoughts?
So I know this is an area people are looking at. So there's certainly some preclinical data, laboratory type animal model systems where potentially THC has been shown to have some cognitive enhancing effects in very old laboratory model systems, which is kind of contrary to what you see actually in younger animals. So there's hints of data that maybe there may be some interesting age-dependent differences in the way THC might affect memory, and that might be relevant to things like Alzheimer's. I know there's also investigation in terms of looking at agitation and neuropsychiatric symptoms associated with Alzheimer's disease and the use of cannabis there as an alternative to things like antipsychotics that are often used in that situation. I don't want to speak to sort of the outcomes of those at this point because I'm not the expert in that area, but I know it's an area people are actively looking at. I don't know, Ziva, if you have any comments on some of the Alzheimer's data or.
Yeah, no, I agree. There have been a couple of studies with high doses of CBD for agitation. And I do know that some practitioners do prescribe that FDA-approved synthetic THC to help with agitation associated with dementia and Alzheimer's and Parkinson's. But, I think that the jury is still out with respect to the evidence that we can hang our hat on if THC or CBD is really effective for those conditions yet.
Okay, well, this has been just a really great, I think, overview, very responsive. Thank you, Ziva, Rob, and Sachin. And thanks also to our audience, very engaged. We've had a lot of questions coming in and good participation. So thanks so much to everybody for what we've done here today, and we'll look forward to following up. So Aaron, back to you. Maybe switch us off, I guess.